We now move to infertility. This is Laurie Doyle and Sam Grayson. How old do you think they are? 20s? 30s? 40s? Here's Ken, Nancy, and Olivia Garner. Kathleen and Gillette Edmonds. All of these couples cannot have children of their own and are writing to me, do I have any couples or any women who are wanting to give their babies up for adoption? This is a major challenge and problem. Here's our case. A 35-year-old patient complains of infertility for 1 year. What are the criteria for infertility? Regular, timed intercourse for 12 months and no pregnancy. What percentage of couples do you think are plagued by infertility? 15%. So this is not rare. Patient and her husband unsuccessful, getting pregnant, no history of PID, used oral contraceptive pills for 6 years, pelvic exam is normal. Where do we go with our infertility? Here are the differentials in terms of diagnosis. Anovulation, semen problem, tubal disease, or unexplained. And unexplained says there's no problem with 1, 2, or 3. What's going on? Okay, this is what we're going to end up with when we are done. Let's first go through our data. Definition. What is infertility? It is inability to get pregnancy after 12 months of regular timed mid-cycle intercourse. 15%. Fecundity is a term which can express the fertility at various ages. This is the percent of conceptions that will occur in 1 month of timed intercourse. And you can see it varies with the age of the female partner. The ideal age biologically for fertility is 20. You can see by age 30, it drops from 20 to 15%. Age 35, it is 10%. Age 40 is 5%, and so on. So by the time you get past 35, you have a significant decrease. This shows the decline again in fertility with female age. Now, at what point would you say does the decline become significant? You know, even in the 20s, you can see it's decreasing. Is it here, age 37, 38? Is it here? There's no question, once you get past 35, it is significant. And many women would love to stop the clock. They may be in a training program professionally, or they have a career, and they recognize that as you wait too long, the odds of successful pregnancy get less. Could we somehow put a switch on our eggs and shut them down? There is work being done on freezing eggs, but it's not at this point widely used. Not only fertility decreases with age, but miscarriage rates go up, as you can see here, after age 35 significantly. By age 40, 45, you're losing 40% of pregnancies which do occur. Babies versus career, a major challenge. Okay, the 3 main causes of infertility. Number 1, is there an egg and ovulation? 2, are there enough sperm, and are they good enough? And 3, can the egg and the sperm get together? Tubal disease. So we're going to look at anovulation, male factor, tubal disease. The 3 main causes: anovulation, 10 to 15%, fallopian tube, 30 to 40%, and male factor, 30 to 40%. We'll start out with the least expensive initial non-invasive testing, which is do a semen analysis and assess for anovulation. These can be done in the outpatient office. More expensive follow-up invasive testing is looking at tubal disease, and we'll do a hysterosalpingogram and, if necessary, a laparoscopy. The most expensive would be if you have unexplained or in vitro fertilization. Let's start with the initial non-invasive. Semen analysis. The normal values are in your notes, and I won't go through that in any detail other than to say we should have a sperm concentration of 20 million per milliliter. If the semen analysis is abnormal, recommendation is to repeat it. Don't just say, well, I guess you can't do it. Here we have one of the largest cells in the human body approached by one of the smallest cells in the human body. How brave these sperm are. Here you can see different kinds of sperm. Look at the shapes of them. This is a normal sperm. This is a hydrocephalic, microcephalic, conjoined twins. You imagine if a pregnancy occurred with one of these abnormal sperm, what would happen? And yet, in a normal male, up to 30% of his sperm may be abnormal morphology. Timing. Obtain the semen sample after 2 to 3 days of abstinence so you get adequate opportunity to examine what is recent production, and examine within 2 hours. This is a figure which shows the weekly sperm counts from a normal man who was dedicated to science, who voluntarily brought in a semen sample over 120 weeks. And look at the variability. What was happening here? What was happening here? I mean, this is huge difference. What if you happen to catch him here? Would you say, well, I guess you can't do it? No, when you look at where his sperm count normally is, you can see it's between 40 and 80 million. So, next step in management is repeat it. What if he has, instead of 20 million, if he's got maybe 1 million? See, a lot of sperm are prevented from entering the cervix by the cervical mucus. Here's where you can do IUI, intrauterine insemination. Washed sperm are injected directly into the uterus. And here we can see is a uterus, here is a vagina, and we have this insemination device where we put the sperm directly through the cervical mucus into the uterus. And the idea here is you put these sperm into the uterus, and where they're aiming for is over here where the eggs are, and you want to give them a boost so that they can go over and do their thing with the eggs. What if the semen or sperm concentration is severely abnormal, maybe just 100? Then even IUI may not work. You're going to have to do ICSI, intracytoplasmic sperm injection. You take one sperm and you inject it directly into the egg, and this always has to be done as a part of in vitro fertilization, because then you have to transfer the embryos back into the body. So here we have 3 sperm. Which ones are you going to choose? There are criteria for selection. You then inject the egg. You put the sperm directly into the egg, just 1 sperm. And here's what it looks like. Boom, injected in, 1 egg. Okay, what if there are no viable sperm? What if he has no viable sperm? That is when you do AID, artificial insemination by donor. And remember, always screen for sexually transmitted diseases because you don't want to have passing along any STDs. And this is an artist's conception of artificial or sperm from a donor who know exactly what they're supposed to do, and they're heading for the eggs to do it. Interestingly, body mass affects sperm quality, and men who are high body mass index, obese, will have a lower sperm count. This was an interesting case where the state appeals court ruled a verbal agreement between a woman and her sperm donor was invalid, and the man had to pay child support for the woman's twins. Better watch out. This is really a remarkable case. A baby born from sperm frozen 21 years before. The boy's father had his sperm frozen when he was 17, when he had testicular cancer. This was in the early 80s. And the sperm was stored in liquid nitrogen. then was thawed when he got married, decided to have a family, and they used intracytoplasmic sperm injection, ICSI. And the baby boy was born. Okay, let's look at ovulation and ovulation. Historically, we've already talked about this, irregular, unpredictable menses. The objective data that you would see, basic body temperature, flat, no mid-cycle rise. Progesterone levels, low. Remember, progesterone comes from either the placenta or the corpus luteum. If she's not pregnant and if she's not ovulating, she doesn't have a corpus luteum. Progesterone will be low. If you biopsied the endometrium, what would you see? Proliferative changes. No evidence of progesterone. We talked about the two correctable causes. Oh, this is the thermogenic effect of progesterone. You can see the rise here of this is an ovulatory cycle. The correctable causes would be hypothyroidism, hyperprolactinemia, so we want to check that out. If she has normal thyroid tests and normal prolactin, we can induce ovulation with clomiphene, which is an anti-estrogen. It feeds back to the anterior pituitary, says we've got too little estrogen, we need more FSH, and so FSH levels will rise. If that doesn't work, you can use human menopausal gonadotropin, which is FSH, which is obtained from the urine of postmenopausal women who have high levels of FSH. Clomiphene usually starts at 50 milligram tablets, and you increase it each month until ovulation occurs. You can go up to 250 milligrams. One of the concerns anytime you do ovulation induction is ovarian hyperstimulation. This is particularly true if you use Pergonal or human menopausal gonadotropin. This is injectable, it's got to be injected, but what it causes is multiple follicular development. You can see how many follicles there are in this ovary. If this happens, don't try to conceive with this cycle. You'll have super multiples. This is a hyperstimulated ovary and the ultrasound. Okay, ovulation okay, semen analysis okay. What now? We want to assess the tubes, and we can do this with a hysterosalpingogram laparoscopy. Interestingly, chlamydia antibodies may be very predictive of tubal disease. If a woman has positive chlamydia antibodies, she's most likely going to have some tubal disease. Hysterosalpingogram, the contrast is injected through an intrauterine catheter, and the contrast should fill up the uterine cavity, go into the tubes, and spill out into the peritoneal cavity. You schedule this the first week after menses. You give prophylactic antibiotics in case there is bacteria in the upper tract. If a normal hysterosalpingogram, you do not do anything further, but if it is abnormal, then you may want to see if you can fix things using laparoscopy. Here we put into the cervix the cannula, and we inject the dye. You can see how it fills up the triangular-shaped uterine cavity. Then we look to see if the tubes are appropriate. And there we can see spilling into the peritoneal cavity, and that's normal. How about on the other side? Okay, you'll notice on this side here that the tube does not allow the dye to spill. This is because you have a hydrosalpinx on this side here. These are some actual hysterosalpingograms, and you can see the T-shaped uterus here. This is a bicornuate uterus. You can see how this is clearly abnormal. Okay, if the hysterosalpingogram is normal, you stop there. If it is abnormal, then you might consider laparoscopy. And the indications are to have potentially correctable tubal disease. If you can do a tuboplasty, reconstruct the oviduct so that they are functional, that would be certainly worthwhile. If the tubes are so destroyed by the adhesions that they are not possible to reconstruct, then take them out. do a self-pingectomy, and then do IVF. And your likelihood of success with IVF is higher if you take the tubes out. And you can see the adhesions, which are all over this pelvis here. This is laparoscopically how one would repair them. Okay, you've checked the ovulation, no problem. You've checked the semen analysis, no problem. The hysterosalpingogram is normal. Now what? We call this unexplained infertility. Unexplained infertility is normal semen analysis, confirmed ovulation, patent oviducts. If you didn't do anything for these patients, no further intervention, 60% would get a spontaneous pregnancy within 3 years anyway. And this is the situation where you probably know of people who have done infertility workup. Nothing was found. They said, well, we don't want to put any money out. We don't have the money. Let's just adopt. So they adopt, and then what happens? Get pregnant. If nothing happens within 3 years, then it probably is not going to. This would be a 2% monthly pregnancy rate. Now at age 20, what was the fecundity? 20%. So this is markedly reduced, but it's not zero. If there is unexplained infertility, we go ahead and do ovulation induction with clomiphene anyway. We do intrauterine insemination anyway and see if that works. Does it work? It didn't. Now it's basically in vitro fertilization. And the indications for IVF, in vitro fertilization, are severe oligozoospermia. This is where you have to do ICSI. Tubes are so bad you can't fix them, irreparable tubes. Or unexplained infertility. Use human menopausal gonadotropin, HMG or Proganol, to stimulate multiple ovarian follicles. Then you do transvaginal ultrasound egg retrieval. You then take those eggs and you do either in vitro fertilization, where you mix the eggs and the sperm in the laboratory, or you may do intracytoplasmic sperm injection. You hormonally prepare the uterus to receive the embryos, and then on day 3 or 4, you transfer embryos back into the woman. So we have ovarian hyperstimulation, we have egg retrieval, and under ultrasound guidance, you put a needle directly into the follicle and aspirate it. The egg will then go into this tube right here. So we have egg retrieval, in vitro fertilization, incubation, and then embryo transfer. How many embryos are you going to put in there? Recommendation is to put fewer than we have. Here's a 57-year-old woman who conceived with IVF. 57 years old with twins. How would you like to have twins at age 57? Consider single embryo transfer on young women so we can avoid these super multiples with premature labor, immaturity, and all the problems from there. Egg donation may be helpful if we have a woman who is beyond her reproductive years. Okay, let's summarize what we've said. The criteria for infertility, 12 months of unprotected sex. The causes, anovulation, basal body temperature is flat, progesterone levels are low, endometrial biopsy shows proliferative endometrium. Management, clomiphene citrate. Male factor problems, do a semen analysis. If it's abnormal, repeat it. If it's still abnormal, you may need to do intrauterine insemination if you have a low semen or sperm count, but yet it's perhaps 1 million. If you only have a few viable sperm, you may need to do ICSI, intracytoplasmic sperm injection, or if you have no viable sperm, artificial insemination by donor. Tubal disease, we screen with hysterosalpingogram. If that is abnormal, we'll do laparoscopy with either repair of the tubes or remove the tubes and IVF. If there is no problem with ovulation, male factor, tubal disease, 1, 2, and 3, no problem, that's called unexplained infertility. Now we're going to do clomiphene and intrauterine insemination anyway, does that work? If it doesn't, we're basically stuck with IVF. Oviducts non-functional, ICSI, unexplained infertility, we will do IVF. $15,000 a cycle. And that's the end of infertility.